So again, thank you so much for taking the time out today. So welcome to my channel, and today I've got Anita Bignell, who has won the Nurse of the Year, and I bet you won the Mental Health Nurse of the Year at the British Journal of Nursing Awards on the 25th of March. So
Yeah,
congratulations.
thank you. Thanks, Sabrina.
You're welcome. So firstly, do you want to introduce yourself, Anita?
Yeah, so my name's Anita Bignell. Obviously, I'm a mental health nurse. I have been living in the UK for about just over 25 years. I started working in mental health when I was about 26. I managed to be seconded to do my training within South London and Maudsley from about the age of 27, 28. And I qualified about 15 years ago, and I've been working in the trust ever since, just because I'm quite a naturally lazy person and the commute is easy, to be honest with you. I live in South London, I work in South London, and I don't want to learn a new IT system. So I'll stick with the one I know. I've
Yeah.
been in the trust so long now, I feel like I know so many people. It becomes a network in itself, doesn't it? So it feels kind of easy to navigate then when you're already doing quite stressful work, isn't it?
It so does. And you sort
Mhm.
of already have given us a flavour of how you got into nursing. And I was reading your story. Just give a bit of a background in terms of.
Yeah, so when I first moved over, it wasn't necessarily a firm choice to move to London. It was a firm recommendation by my dad, who was feeling quite frustrated with my lack of progress in my life. I had very strict Irish parents growing up. So I moved over here and I was living with my auntie, who was a general nurse. And in order to meet people, first of all, I worked in pubs and I worked in nursing homes. So I did a bit of both. Part-time of both, and the pubs took over for a while just because it was easier to meet people. I met my husband, we started running and managing pubs together, and I had a huge kind of friend network as a result of that as well. So it was, I think when you're in your early 20s, pubs are a great place to work. I was never a massive drinker, so it worked for me because I didn't actually, I think it's a problem if you drink and you work in pubs, but I was never a big drinker despite being Irish and all of those stereotypes. So had a really nice few years running pubs, but kind of realized that it probably wasn't going to get me anywhere. It became very unsatisfying. I started to feel very guilty about serving people who were obviously alcoholic or having problems. And I felt that I was actually adding to their problem rather than improving it, if that makes sense. And then my auntie was a general nurse, and she said to me, look, if you go and work in the NHS, as a support worker or a nursing assistant, they'll pay for your training. And at that point, I was never going to be able to afford to go to uni without receiving a salary. I needed a salary. I needed to pay my bills. So I went and I worked as a support worker at the Bethlehem, which is part of South London and Maudsley. And part of that reason was because it was quite convenient because my auntie's house was across the road and the job was advertised. And I went to the interview and I just loved the people. You know, when you feel like you found your people,
Yeah.
we just clicked, and we almost, even in the first interview, we were having, as much as they were asking me really serious questions and checking me out as a person, I just knew that they were the kind of people I could get on with day to day. And they were really quite passionate about their work, which I never do things by halves. I'm in or I'm out. So that I kind of thought, I can get on with these people. They'll get why I'm so kind of passionate and committed to things. So I worked on that ward as a nursing assistant, and it was a specialist unit for people who self-harm. So lots of the patients had quite kind of chronic self-harm presentations. And it was based on kind of psychodynamic therapeutic community principles. It was a national unit, so we took referrals from all over the country. And we did work with quite severe self-harm, so that was tolerated within the unit. So we would deal with patients who were cutting themselves and overdosing, and we would kind of accommodate their care needs according to that. And I think probably part of the reason why they took me in was that I didn't have other mental health experience, because I think if I'd had other mental health experience from acute wards, I would have really struggled with that concept. But I was quite fresh eyes into it, so they were able to kind of train me into the way they wanted me to work. But yeah, I did that for 2 or 3 years and then was seconded to do my training. So I was really lucky. I went to King's, which is a really good and at the time I had no clue just how lucky I was. But King's is just an amazing university. I think training in South London and Maudsley, you've got such a diverse kind of clinical areas. You get so many experiences here. So yeah, I feel like I've probably been very lucky throughout in some ways. That in some ways it's like the stars aligned at that time for me to do that, because I've definitely felt a lot more fulfilled since I've become a mental health nurse. That it sits with me. It fits my kind of values.
Yeah.
It gives me a sense of purpose, and it's really challenging intellectually actually as well. So you get so many different things from it that I think other jobs you can't get that actually. So yeah.
That's such an amazing journey, because I know eventually that route into nursing sort of stopped. Now it's come back in a little way with the nursing associate and associate practitioner role, where you can do an apprenticeship. But you know, it's so fantastic that you're able to, like you say, find your tribe, find your calling. And when you did your nurse training, because when I qualified, I did a diploma. Was it a diploma then, or was it a BSc?
Well, I was again really lucky, because at the time everyone went into the diploma, and then after the first year, if your grades were good enough, so most other people were on that full bursary. So the bursary was still quite good then. And at the end of the year, if your grades were good enough, you were offered the degree pathway. And actually, most of the people I'd made friends with, because they were on bursary, they couldn't take that pathway. But I was lucky enough that because I was seconded, I wasn't going to lose money, because at the time you lost loads of money by going on to the degree. So I managed to move on to the BSc pathway and got the degree as well.
Really good to hear that you had the option. So you came out with your BSc in nursing. When you were doing your training, were you still doing shifts on the wards, or were you like seconded out properly? What did that look like?
Fully seconded out properly. So I got it was at the time, I think it was an A or a B grade. It was back before we had
the old Whitley system.
Is that what it's called? Oh my goodness. So I got it was A grade. I was probably on 15 or 16 grand a year, but still at the time able to pay rent in London and bills in London. So zone 4, and got my student discount travel. I actually saw more of London, because I used to pay for my travel card for the week or month with my discounted travel, and then travel all over the place to gigs and different things. While with my student travel card, it was like I really enjoyed those 3 years, because I didn't have to think about the cost of the travel card.
I trained outside London, but like you said, when we went to placement, you got you could reimburse, because I was on the bursary. But it was so fantastic, wasn't it?
Yeah, really good. It just, I don't know what it was. I just got I felt like there was a lot of freedom with that. I think it's a huge loss. I think I would never have gone to uni if I didn't get that salary. I couldn't have afforded even the bursary, because I was paying too much rent to even take the drop with the bursary. And I also just think that there's something about, like, I suppose now I'm probably middle class, but at the time I was, I'm from a working class background. But I would imagine there are a lot of people from working class and other minority backgrounds that can't access training now because of that. And I just feel sorry for nurses taking on debts, because your starting salary as a band 5 isn't enough to take on student loans. I just don't think that money is enough to have that much debt behind you. I think is really sad to start your career like that, actually.
I remember when the suggestion moving to student loans, and as we know, for some nurses or people deciding to do nursing, it could be a second career option. We've got a lot of especially in mental health. There's lots of women in there, and people have other responsibilities. So it is potentially a burden. So I do echo your thoughts on that. And currently, Anita, tell me a bit about the the role that you're doing, and then I guess your journey to this current role?
Yeah. So at the moment, my official job title is lead simulation nurse tutor, which is part with Maudsley Learning. So Maudsley Learning is officially part of South London and Maudsley, but the idea of what we do is that we create education and we deliver education, and we generate some income through that is then fed back into South London and Maudsley so that it goes back into patient care. So we have a number of kind of revenue streams. So most of what we do is we apply for bids and grants, and we also provide training and education to acute trusts, so to general hospitals, and a lot of that is about kind of teaching them how to work with mental health presentations and primary care. We do this as well. So we're teaching them how, we're trying to reduce stigma basically and help them to work with patients with mental health needs in a more effective way, so that we're trying to reduce that health gap that we have. So, as we know, we've got this 20-year health gap between people with a mental illness diagnosis and the general population. So a lot of the training that we're doing is about trying to reduce that gap and kind of reduce the stigmas, but improve knowledge, awareness and skills. And we do a huge range of courses to do that. And we also provide training within SLAM. We do more kind of specific courses about various mental health presentations and how you might work more effectively with those patients. So the core of my work is the simulation training. So for that, we recruit and train actors to be able to play various mental health presentations in a way that feels really realistic and true to the clinicians, which it resoundingly is. So we're creating this really high fidelity simulation. We ask the people on our courses to go in for about 10 minutes to meet with the simulated patient and to go through a bit of a role play scenario. We'll give them a task and ask them to go in and interact with that person. The rest of the group watches that, and then for about 30 or 40 minutes after that, we use usually the Maudsley debrief model. So it's a model that we've kind of developed over time, where we're using kind of psychological principles and various other elements of clinical debriefing that we've incorporated into a single model within the team. And we spend time, so we'll get a shared description from the group. So we'll get a shared mental model of what we've just seen in the scenario. And then we'll break it down for about 30 minutes and talk about all of the kind of, if you've heard of human factors, so the non-technical skills that prevent us from carrying out patient care as effectively as we'd like. So it's all those kind of environmental factors and the interruptions that we might experience during clinical work, decision-making, prioritization, triaging, all of these things that have an impact on work that we can't really learn on traditional courses. And so simulation kind of allows us to think about that. And I think over the last 2 or 3 years, we've incorporated lots of elements of equalities and equities into that as well. So we're addressing consistently how our unconscious biases influence the patient care that we're delivering. So we do that in various settings. And I just love the job because it incorporates my kind of clinical experience. And because I think you need to have quite extensive clinical experience before you can do this effectively. So we've got this underpinning kind of basic assumption about we believe that everyone who comes on our courses is there to learn, and having that, which really I think chimes with that unconditional positive regard, that if you use that in your nursing practice, you get so much more out of your patient care. And trying to incorporate the basic assumption into our teaching practice, we often have our people leaving the end of our courses just feeling really happy, really content, and really enthusiastic about implementing the skills and developing themselves further. And it's a really rewarding kind of piece of work to be doing, actually, and knowing that it's going to improve mental health patient outcomes as well when they're in various services is really nice.
There's one thing being in a classroom and being taught, but actually going in an immersive situation and then discussing it, because that model, because different people see different parts of it, I find, and it's having that reflective on action after action and thinking about how you could do things differently. That's where the real, I think, learning comes from.
And it's so interesting that you say about the reflection on action, because that Donald Sean one that you learn in your reflective practice model in undergrad, that one really stayed with me, the reflection in action and on action. And I think that's what simulation does perfectly. And it's when we're in practice, we're doing things, and 10 of these things can happen to us in maybe an hour, and we never get a chance to unpick it. And when you give people a space to unpick it, we can learn so much more. And it's really empowering for those people to kind of have had a chance to do that and improve their practice. And actually, we did an undergrad week last year. So we had a group of undergrad nurses for 5 days, and we did 3 simulation days with them. And we did various kind of workshops and different things with them. And by the end of the week, they were saying that it was one of the best weeks they've had out of all of their training, because we formed this really solid group for the week. It was really nice. And you could see them develop through the week and start to really implement skills and take risks. And when we get that really nice group feeling, it's really nice on our sim days. I do really enjoy it.
To do a role like this, it does take a lot of your clinical experience. So how did you get into this role, Anita?
So I actually, as a newly qualified, I worked in acute for 7 years as a band 5. So when I qualified, I basically I qualified and got pregnant pretty much at the same time. So that really stalled my career for a few years. So I remained at band 5 because actually the ward was really flexible with young kids. So I was able to do long days and mix and match my shifts and request days off. It's really flexible when you're on a roster. And my manager was really flexible. She really accommodated parents' needs and everyone, like not just parents, but everyone's needs. She try and make it work for you, which when you're kind of band 5 and young kids, that's the environment that kind of works for you at that point a lot of the time. And again, I didn't really have money for childcare, so I needed to make it work. I needed to juggle, and I couldn't pay for childcare. As a band 5, though, you're bottom of the heap in lots of ways, because you don't really have the seniority. You don't necessarily get taken seriously by the nursing assistants and everyone else, but you're also given huge amounts of responsibility on an admissions ward, and you're actually responsible for the safety of ours was 16 beds, but 16 acutely unwell patients with mental health needs and often physical health needs comorbidly. And it was just unbelievably stressful. It's a huge learning curve, but I did some simulation courses. I did 1 or 2 simulation courses at that time, and it just really helped me to step out of my practice, think about what I wanted to be as a nurse, and to just reassure myself that some of the things I was doing was really good, but also develop new skills and learn new things from other people. And there's something really nice about sitting in those simulation debriefs and hearing that other people are struggling as well, even people much more senior to you. That's really reassuring, because I think you sometimes, as a band 5 or newly qualified, you think it's that you're really stupid or that you're incompetent, and you don't necessarily want to put your hand up and say, oh, I'm really struggling here, because you don't know how people are going to respond to that. I did that, and I think all the way through working as a band 5 and on the wards especially, the human factor stuff always really appealed to me, and that Swiss cheese model, because often the incidents I was dealing with were as a result of those human factors and Swiss cheese issues. It wasn't necessarily that anyone was particularly incompetent or that we were bad at our job. It was just that often incidents occurred because of poor communication. Maybe we weren't aware of the environment, or, you've got so many handovers in healthcare that something often gets missed, and suddenly you've got a major incident on your hands, when actually it's because we've miscommunicated somewhere before that. Built up my skills over time. I worked in a bipolar service and learnt a lot about that in a day service. And then I went.
You not just worked in the bipolar service, you did help to set it up because it was quite
Yeah,
new,
yeah,
wasn't it?
yeah.
So don't
So
underplay. We usually do that as nurses and as women, underplay the skills.
yes, so me and my nursing colleague Charlie, we actually, we developed all the nursing protocols for that service. So
Yeah.
we set that up from scratch, and that was just a completely new way of. I think the purpose of Optima was to reduce readmissions for people with the most severe forms of bipolar. So people who would be having maybe annual or twice yearly admissions due to mania or depressive relapse. And the idea of that, again, was about not just addressing the mental health, but also the physical health. So we had like a whole nursing protocol where we do a physical health assessment and try and do lots of kind of lifestyle changes and some group work and psych ed about managing your meds, but also managing your physical health and being more active and managing diet. And we had a really big OT focus in there as well. So the OT did lots of behavioral activation. I learned loads about behavioral activation from them. And we did that really, it just felt really holistic. It was really nice, actually. And we wrote groups and we ran groups on sleep. I loved my sleep group. I'm still obsessed with sleep hygiene now. I think it's really important. And obviously in bipolar and mood disorders, sleep is a huge factor in whether or not people stay well. And sleep disturbance is such a big part of relapse in bipolar, either mania or depression. So yeah, goodness, we did loads there. It was really good. And it was really nice to set something up from scratch and kind of, we made it look really nice. You know, the environment was lovely. And it's lovely when you create I love being able to, and I don't think we do it enough in mental health. I think if you're meeting a patient, whether that's on the ward, in a day service, in outpatients, I think we should be trying to host people. So are we offering them a drink? Are we welcoming them in? You know, I always tried, you know, I'm not saying I succeeded, but I've always tried to, you know, treat a patient who's coming in to see you, treat them as if they were a guest in your home almost, because it's a really new environment. It's really scary and they never know what they're going to be dealing with. So if you can get someone a drink, host them and make the environment look nice, that's, to me, that's really important. And we can't always do it. And I think especially in acute wards, it's really challenging because there's often, but in Optima, we got to host and have a really pleasant environment and give them nice tea and coffee and snacks and just do all of that. And it was just really, you could see that people enjoyed coming to their appointments a lot more when they had a nice environment to sit in and comfy chairs. I went to assessment and liaison. So
that's a community team, isn't it?
Yes, it was a community team, and it was basically Optima was a band 6. And then, so what was really interesting was I realized, so I stayed on triage. I kind of had a bit of a knock on my confidence, I think, after having kids as well. So I stayed there for 7 years as a band 5, and I didn't feel confident to go for band 6. And I think I made the decision early on that I didn't want a band 6 on the ward because the money is too good. And I think you get stuck in it, actually. And I knew I didn't want to stay on the ward for long term. So I didn't want to take a band 6 and then moving on just feels too expensive. You can't lose the money. So I went to Optima band 6. I probably stayed on about the same money or lost a bit from doing that, from going band 5 on the ward on shifts. But again, my kids had started school, so it was more 9 to 5, and I could work that around the kids much more easily. So it was my opportunity to do something that I wanted to do as well, like a job that appealed. And it was really exciting to set up a service from scratch. And then I think doing Optima, it made me realize that I could do the band 6 quite easily there. And I'd spent so long as a band 5, and I'd seen other people spend much less time as a band 5 and kind of go through the ranks. And why was I second guessing myself all the time? I kind of realized I keep second guessing myself, but maybe I should, you know, I've read something about how women wait until they can do their job and then apply for it, whereas men think I'll learn on the job. And so then I think from being an Optima, I thought, oh, you know what, maybe I should just take a risk. I'm good at building rapport with patients because on triage you learn to build rapport really quickly because it's an admissions ward, so it's quite quick. And I knew that I had a bit of an interest in kind of personality, self-harm, suicide, risk assessment, and assessment and liaison gives you a lot of that. And I love doing assessments. I used to love the assessment part of working on triage as well. So assessment and liaison just felt like a really good next step, and it was a band 7. And I thought, you know what, I've put the time in at that point. I felt like I wasn't just skipping through the ranks for the sake of it. It felt like this is justified for me to go for the 7. I knew I didn't want a management band 7 as well. I knew I wanted to stay in clinical for as long as possible because I just love the clinical work. And managing teams didn't appeal to me at that time. So yeah, I went for the A&L band 7. I thought, well, I'll give it a go. And if it doesn't work out, it doesn't work out. I've still got a job, you know, and you just meet amazing patients as well through that job. I got to really, because it's a clinical band 7, you've got quite a lot of control over the work you do. So you've got a lot of control over your caseload, and what referrals you accept or reject. You've got a lot of say in that as a band 7. And the team was well organised. So if you went on annual leave, you knew someone would pick up it. You know, I didn't have to go on annual leave and worry about my patients for a week or two. And I think in the community, that's a big thing, actually. I didn't want a community job where people would refuse, and we had a really good duty system. So you get a real insight into what primary care do in that job. Because GPs work so hard, and some of the don't see GPs, and they knew that patient inside out. And it was amazing. Like, it still amazes me how much information GPs can retain. Because, you know, there was one woman I worked with, without naming names, but she was a chronic alcoholic, and I think had made several suicide attempts. And you know, the first time I met her, she was still using alcohol quite heavily. So I had to write letters to GP and say, we're not the appropriate service. I've asked her to engage with alcohol addiction services. If she gets that under control, please send another referral back. 6 months or a year later, she's got the alcohol under control. Can you see her again? She's still having, you know, very low mood and whatever else. So we see her again. You know, she's got other things going on. She's got social issues at this point. Can you sort out her housing? Can you do this? We give her a bit of support and signposting. She wants some therapy at that point. We kind of say, look, you're probably not quite ready for therapy now, but in 6 months, I think you will be. She goes off. You know, we do a few little social things with her, signpost her into social services for housing support and financial support or whatever. She went off, did whatever she needed. She came back to me 6 months later, you know, a bit more stabilization needed, asking for therapy referral. I'm like, yeah, you're at the right point now. Your housing is stabilized, your addictions are stabilized. Let's refer you in. She needs, you know, she does need long-term therapeutic input from a secondary mental health service, but we have to give it to her at the right time. But me and her GP did a piece of joint working. We were back and forth. She'd pick up the phone to me, I'd pick up the phone to her, and it worked really nicely. And she wasn't necessarily on my caseload all of that time, but probably over 2 years I saw her fairly regularly, but you know, not consistently on the caseload, but still knowing that she can come back and see me if she needs to, and the GP can pick up the phone. And that there's something, I think the GPs need to know that someone, well, we need, like, I found it reassuring because her GP had good intentions. So I knew if I'm discharging her back to the GP will send her back if she needs me. And the GP knows that if she needs me, she can call me. And it, you know, there's something really nice about having that relationship if you can build it. It's
that easy and easy out access we talk about, and putting it into action. See why you've got the award, Anita. So tell me, what's a day in the life of a simulation nurse look like?
Different days depending on whether I'm teaching or not. So on a teaching day, I'd be running, ideally I'm running a simulation course. So in the run up to running that, you have to book your actors, you write your scenarios. So we, on a typical simulation day, we have between 4 and 5 scenarios. I think we used to routinely do 5 or 6 when it's face-to-face, but because we've moved most of our training now online, we've reduced the number of scenarios just to reduce the cognitive load of participants, because obviously it's really interesting. Clinicians, we actually love that face-to-face and contact, and so it's harder for us online to do all that concentration. And especially when you start my day around 8, half 8 on a teaching day, we kind of log into Zoom and we'll meet. we've got really good tech support with multi-simulation. So we have tech who set up the Zoom links and run all the technical things in the background. So and then we'd meet with the actors, prepare the actors for the day ahead. We'll run through our participant list, just check in that that's happening. And then our techs do a quick 10-minute onboarding just to make sure people's cameras and mics are working, and help people resolve issues with their Wi-Fi and this, that, and the other, because if they're not used to being online, there's usually some kind of chaos that we need to help sort out and just calm down. And then we, on a simulation day, we do about an hour of icebreakers, intros to the day, housekeeping, and just, it's really that kind of group dynamic where you're trying to create a group for the day. So you're creating what we call psychological safety. So you want the learners to know that they're going to be listened to, that we're interested in them, that it's a safe place for them to take risks because they're going into the scenarios. So we're asking people to expose themselves. So they need to feel confident in the facilitators that we're going to show them respect. And we set quite clear ground rules. So we're asking our participants to all show the same respect as well. And we're doing lots of role modeling. So we're being quite clear about our expectations from the start of the day. That takes about an hour, hour and a half to settle people in. And I think we do these kind of icebreaker things, which the icebreakers look like fun, but there's quite a lot of learning theory behind that as well. So it's about creating that sense of respect and making people feel valued. On the nursing undergrad course that I mentioned earlier, we did a great one about a teacher they'd had or a mentor they'd had that they kind of carried with them. And the stories that our participants told were absolutely amazing. Most of our participants on that course were actually either Nigerian or Ghanaian. Mm-hmm. So they're on the course, they were doing MSc, I think most of them. And they had amazing stories about teachers or uncles or aunties and things like that. And it was really lovely to hear their really rich descriptions. Yeah. And it kind of, so that creates that kind of reverie or nostalgia in people as well, where they start to feel a bit warmer and relaxed. So it's just really nice. And then we run usually about 5 scenarios. So we'll have different learning objectives for each scenario. We'll send people in for about 10 minutes. And on a typical day, so one of the big courses we do at the moment is reducing restrictive practices for acute trusts. So on that course, we'll have the first scenario will be a patient who's either psychotic or delirious, who was admitted and has been in ITU. And we ask the nurses to go in and just try to de-escalate him. We then come out and we debrief. So we'll help them to kind of develop more of an understanding of his mental health presentation, his physical health needs, how the two might be interacting with each other to create that presentation, and to explore a bit more about effective de-escalation and ways we can reassure patients who are scared and psychotic, let's say. Then the second scenario, on that day, we often have a patient who again is angry, but who is angry for different reasons. So he's taken an overdose, he's on Parvalax treatment, and he's starting to become quite restless. He's been quite low in mood before admission. He's made this kind of suicide attempt. It's not clear whether there was intent or not to end his life. And we ask the participants to go in and speak to him and kind of do a bit of a risk assessment, a bit of de-escalation. And sometimes in that scenario, we also bring in a bit of that kind of splitting where he's nicer to one participant than the other. And again, sometimes we layer that up with not just splitting, but is he being a bit sexist to the female participant? Is he being less respectful to the female participant than the male? And then when we come out in the debrief, we explore all of those factors. So we think about kind of, you know, and we talk about diagnostic overshadowing in that one. So what we'll find is we're focusing loads on the splitting behavior and on maybe him seeming quite irritable. But what we're missing is that we're risking him leaving treatment, not finishing treatment, and not having a full suicide risk assessment done by a psychiatrist. So we'll explore that in the debrief and how we might keep that guy safe. Then we have other scenarios, various scenarios through the day, but I won't tell you the whole thing. That's a typical teaching day, but then we do loads of writing. we do lots of linking up with an R&D team. So courses have pre and post course questionnaires, and we write course reports. So we have very clear evaluations and clear feedback. We make changes to all our courses on the basis of that. So if something hasn't worked, we'll make constant changes. We're constantly, they all laugh at me in the team, I'm constantly tweaking on a course and rewriting something later in the day because of something that's been raised in the intros. And I really like to respond to learners' needs. And then we also, we have actors that we have to link up with, loads of writing, just loads of kind of project management, I suppose, trying to make sure that things come in on budget as well, which is probably a bit different to most clinical work. I think we don't necessarily worry about the budget so much in clinical. And then I'm also getting to do lots of kind of, a bit more now, conferences. So we'll submit our abstracts and presentations and different teaching projects we've done. So in June, we're going to Seville for a conference and we're going to present loads of our courses. And then in the last year, one of the things I've really enjoyed is because we do debriefing every day, we've taught debriefing skills, but a briefer model in Lewisham in the Ladywell unit. And so I've been teaching staff who work in acute wards debriefing skills, and they've been implementing that model in practice. So the idea of clinical debriefing is that you're going to improve patient safety and reduce staff burnout. And I've really enjoyed that, actually. It was really successful at the idea of staff getting skilled up in that so that they can start identifying the human factors. And actually, with the couple of years that we've all had with COVID, it'd be really nice if it reduced burnout and improved kind of things like that as well.
Fantastic. It sounds so exciting, your role, but also the different experiences that you're getting. So you're doing a bit of the writing of the course, but also linking in with other people. Think about budgets. That's one thing that we don't get taught as nurses, but as you move up the ranks in different roles, especially if you're in a managerial role, all of a sudden you get a budget, you have to read it. And it's just
and it's like there's literally no training on that, is there? It's just you get into a managerial role and suddenly you're managing a huge budget.
You sort of go, what does the red bits mean? And there's brackets around. I realise if you've got a bracket around a number, it means it's in negative figures, but
Oh my goodness, I don't think I even knew that.
But so let's move on to when you found out that how did you find out you were nominated? Did you know you were nominated?
I didn't know I was nominated. The doctors in the team, one of the doctors nominated me. And I received an email. It had zero branding on this email. It was just looked like it was from anyone. And because we keep getting spam emails, I forwarded to my manager, one of the guys I work with, and I said, is this a spam? Before I get excited, please, because it said it was the BJN Nursing Awards, but it was so unbranded. And he's like, no, this looks genuine. And so I got really excited. It was only about 3 weeks before the award ceremony as well. And my husband's a musician, so he already had a gig booked that night, and we're not turning down money after the pandemic. So I arranged for one of my nurse colleagues to come with me. So it was a huge, I wasn't expecting it. It was a huge surprise.
I was so pleased when I heard that you won. So congratulations.
Oh, thank you.
Again. And just because we're going, any tips you want to give to people listening in, because you've got such, what I'm hearing is there's a bit around making sure you get your experience, choosing the job that's right for you, thinking about who your manager is, but also thinking about the patients that you're working with, knowing the team that you've gone to, etc. But also not doubting yourself, so not thinking you've got to have 100% of the job description, because I know us women do that, and more so BME staff as well do that. So any tips in terms of how people can, progress in their career?
So now that you've mentioned BME staff, I am going to say that part of the reason why I'm so keen on doing the equities is having worked on the ward for 7 years. I was often the only white person on shift. And people would walk into the nursing office when I was on with senior band sixes who happened to be black, and the person would assume that I was in charge because I was a white person. They would literally make eye contact with me and ask me questions, and I'd be like, you know what, there's much more senior nurses than me here, you need to talk to them. And that didn't just happen once, that happened once a week, and I worked there for 7 years. So this happened routinely. Lots of the black nurses I worked with, they had to pay for their own masters. They applied for band sixes and didn't get them, and other people with less experience and skills were given them. So for me, one of my big things in pushing the equities in mental health education is actually I'm really passionate about supporting BME colleagues to do their job and to be rewarded for the work they're doing and recognised for the work they're doing. We do have quite a diverse team in Maudsley Learning, and we're increasing our diversity all the time. So I'm really committed to that. But I also think that if you're not getting the thanks for your work, go somewhere where you're going to get the thanks for it, because I've seen too many nurses not get the reward that they deserve, if that makes sense. And I just think it's really sad, because we've got some amazing nurses out there. And I think there's just so many factors that play into that, because I think as a woman, we know that over 80% of nurses are women, and then 80% of our managers are men. Why are we giving all these, I'm sure lots of them are really capable, but there's absolutely no way that many of them are more capable than this many women. And we're often working outside of, women are usually doing an extra 10% of their workload. They're not just doing their JD, they're working outside of their JD. Whereas I think men are much more able to maintain their boundaries and just do the work that's going to get recognised. I was reading something about this just yesterday. And I think sometimes we need to regularly take step backs. We need to give each other positive feedback. I think as women, we need to support each other. We need to support minorities who are in the job, and give them positive feedback, because I think people aren't hearing that enough, and we start to lose confidence. But I will also say that don't jump out of the frying pan into the fire. If you're not feeling happy in your job, don't go. I've seen so many people go to agency, and while I know that's rewarding, I do think you don't develop your skills as much as an agency nurse. And I think you need to find there are places that will recognise you for your hard work and will reward you for your hard work. And we need to use our networks to find those places. And actually, we do have networks, and we've got informal networks. I regularly get into contact with the nurses I worked with on the ward. If I see job vacancies or I see something that I think looks good, I'll contact my ex-colleagues and say, this looks really interesting. Have you thought about applying for that job? You could do this. And I'll try and give them a bit of a push. And wherever they're working, just because I think that's what my friend did for me. She saw this job and sent it to me and said, Anita, you'd be perfect for this simulation nurse job. And I wouldn't have even thought to apply for it. I didn't think I'd be good enough. And she's like, no, go for it. And I think women, we need to be supporting each other to do that, and giving each other positive feedback, recognizing and noticing when people are doing a good job, because I've seen some incredible nurses that kind of go to agency or kind of don't progress. And I just think it's a shame. I think the NHS is losing out when we don't recognize people as well, because I think in all sorts of ways, it's affecting patient care ultimately, isn't it? We know that it's affecting patient care, that we're not promoting the people that need promotion. And I think it feels a bit risky at times, but I just try to bluntly call things out now. If I attend meetings and everyone's white, I'll say, why is everyone in this meeting white? And my friends laugh at me, and I'm like, we need to say it, like, why is it all men? Why is it all white? Why, and I think because I'm white, I can say that, and it's easier for me to say that. So I need to take that risk a bit. But obviously, as an Irish person with an accent, I've got other risks for that. And I do get backlash at times. But I think I'm kind of lucky now, because in simulation, they really humour me being a bit stroppy and a bit rebellious. So I've found the right place for it. And I think the work that we do is so much about stigma and patient outcomes. We can't shy away from it in education, because we're getting the latest evidence all the time. We're conveying that latest evidence. And so we have to commit to equity in other areas as well, because there's no point in teaching equity and then not doing it in your own team.
Yeah.
You need to have all of it going through.
That's
a jumble,
no, it's amazing what you said. There's, how we recognize each other, use your networks, definitely.
Yeah.
And thank you so much for being not only a sponsor but an ally for, other BAME nurses, but also recognizing that you might have faced discrimination yourself, being of Irish background. So, understanding the different faces of discrimination that we all might face and how we support each other.
Yeah, and I think, I do feel that I've got a lot of white privilege, and I think some Irish people, sometimes we get into colluding with it a bit. So I think I'm really cautious of, but also like it's so challenging, because I think English people quite often just think that Irish people are an extension of themselves. They think we're just another region of England, and actually in Ireland, half of my history is about what terrible things the English did to us. Yeah. So we've got that in our heads. But we need to, I think Irish people, sometimes we shy away from that, or because the Troubles are officially over, we forget there's still ongoing issues there. Our country is still divided. And I think but we also do have white privilege. So it's a real challenge, because I think when I walk into a room, I'm still probably going to get more respect than a lot of the Black nurses I work with. And I think I'll name Black nurses directly, because in South London and Maudsley, I think they're the group of nurses who are most affected by discrimination and systemic issues. I realise there are other minority ethnic nurses, but in SLAM, I've mainly worked with like Nigerian, Caribbean and other kind of from other African countries. Yeah. So they're the nurses that I've seen most affected by discrimination. And so I think I feel a certain level of, I don't know what it is. Like I feel like they deserve some kind of loyalty when I'm in a meeting and can say something, or do you know what I mean? But it's really challenging. It's really difficult. And it's just really sad when you see people get a bit burnt out by it. When they're really, really good at their job, and they should be rewarded and respected for it. I've met very few immigrant nurses who aren't also sending money back home.
Yeah, that's true. Yeah,
I don't have to do that. I support myself in the UK. I never have to send money home. I did in my early 20s when I first moved to the UK, but I haven't had to do that for years, because there's been economic progress in Ireland. Yeah. But, I can come to work and all I have to think about is work. Most of the immigrant nurses are not just thinking about work. They're thinking about how are their families doing back home? Are things okay? I don't know how many times there's like awful weather events or something happens in the rest of the world, and I'm actually quite oblivious to that, but that's probably really having a massive impact on a colleague. And we may not even know that that's happening at that time. And I know there's been times when things have been happening in Ireland, and most of the English people that I'm working with are completely oblivious to it. Or even like my immigrant colleagues, because you're not keeping an eye on Ireland if you're not from there. Yeah. But there's something that can feel really draining when you're going to work and something big is happening back home, and you're feeling completely disconnected from your place of origin, and then you still need to go in and do a proper day of work. I just think I try to be as aware of that as I can, and kind of just go the extra mile to support people and make sure they're getting the respect they deserve at work day to day.
Yeah, and thank you so much, because you're right. A lot of people don't recognise that. I think it's termed the sandwich generation, because I'm similar. I've got elderly parents at home that you do have to look after. You know what I mean? So it is. So yeah,
that's a big thing, isn't it? Because I think people are having kids later, so they end up with elderly parents to look after and teenage kids at the same time.
Thank you so much for your time today. This has been so enlightening. I'm sure I'll invite. I wanted to ask, if you don't mind saying, is what banding is your current role, and just the because I don't think we talk a lot about salaries in nursing for some reason, and just the salary that attracts.
Okay, so at the moment I'm a band 7. I've been acting up without the pay for about 6 months or a year, into an 8. And I think that is, I'm going to get my 8 next month or the month after. It should be next month. About 40k, I think, with band 7, 40, 41. I think that's probably before tax, or I don't know. I think it's before tax. And I'll be on hopefully 45 or 50 once I'm an 8.